Hello, everyone. This is Dr. Khan, Executive Plastic Surgery, Bloomfield Hills, Michigan, and Los Angeles, California. So many patients ask, what is plastic surgery? And what are the many different aspects and facets of plastic surgery? Plastic surgery is a very broad field. And this is a field where if you look at the many plastic surgeons who practice on a regular daily basis, you will see a lot of plastic surgeons are hand surgeons. So this is an integral part of our training. We do a lot of flaps, hand reconstruction, mangled hand amongst hands that have been blown up from, like, for example, an explosion, for example, or patients who have congenital hand deformities, bone fixation amongst others, tendon repair, nerve repair, lacerations, crush injuries to the hand. So this is very much an integral part of plastic surgery. Plastic surgery obviously also covers burns. A lot of burn centers, patients are managed by plastic surgeons. You have the world of craniofacial plastic surgery, where a lot of kids born with congenital deformities, abnormalities of the face, body, giant nevi, for example, moles, for example, growths, extensions, they are managed by plastic surgeons. Another big aspect of plastic surgery is flap cancer oncologic reconstruction. This is where a patient may have a big tumor of the leg and they remove it. Now we have to cover the wound. So cancer oncologic reconstruction. The jewel or the heart and gist of plastic surgery is breast reconstruction. Patients who have undergone lumpectomies and now they need to have tissue transfers, for example, or mastectomy patients who need reconstruction, and implant-based reconstruction. 90% of reconstruction that is done after breast surgery is implant-based reconstruction. And so this is an integral and what is the jewel of plastic surgery. Patients who need transfer of their abdominal fat, for example, this is the deep flap, deep inferior epigastric perforatal flaps, or other flaps from other parts of the body are brought in to reconstruct the chest. There are patients who have skin cancer, and so skin cancer excision, amongst the many other aspects of growths, abnormal growths, masses, whatever may arise, are basically taken care of by plastic surgeons. Patients who have trauma to the face, lip, nose, ear, and they have big wounds, open wounds, complex wounds, wounds by radiation, wounds by burns, amongst others, are handled and managed by plastic surgeon. I remember one of my mentors saying that plastic surgery has 3,000 procedures, and this is where the knowledge base by the surgeon comes into place. And remember, we are always learning, evolving. We go to conferences every year and every month, and we hear about the many other aspects of reconstruction that are done. So it is a very much evolving field, very intriguing, and a surgeon has to keep up with not only the advances in medicine, for example, AI, but also what is interesting about plastic surgery is you may have a patient that may come in with one problem, and if that patient goes to 3 surgeons, 3 different solutions may be what were given to that patient, and each one of them may be right depending on the nature of the reconstruction. A patient may have a hand injury, but if that patient is a piano player, is a very different reconstruction, if you will, depending on that patient's own choosing, compared to someone, for example, who is a diabetic patient who's elderly, may need a different type of reconstruction. So within the world of plastic surgery, there's so many different aspects, and this is why it is important for the patients to do their homework and understand what is the surgeon's knowledge base and expertise into doing and offering the surgery. I will end with this on my end. You know, here in the Motor City, we deal with cars, and my mentor told us once that if you have a transmission problem, you go to the transmission expert. That means all what they do from 8 in the morning till 6 p.m. is transmissions. They do not deal with engines, brakes, other aspects of the car. They're not the body shop. They're not the alternator people. This is all what they do, transmissions. So whenever you seek a surgeon out and you want to do a nose job, you want to basically go to that cosmetic surgeon who will deal with only primarily noses, and noses is his specialty. And this is another big aspect of plastic surgery, cosmetic plastic surgery. So it is important for the patients to have done their homework when it comes to explantation, for example, so that they know that this surgeon does exclusively this, and he's the expert, and he's the voice, and he will give expert opinion for the patients to get the best knowledge base and best application of the surgeon's knowledge. Ahmed?
That's it.
So that's it. So now I will do the second question. So I kind of put the two questions in one.
I mean, you can just keep talking.
Got it. Okay, so let me go ahead and do that. Hello, everyone. This is Dr. Khan, Executive Plastic Surgery, Bloomfield Hills, Michigan, and also Los Angeles, California. I want to go ahead and discuss a very interesting patient that I took care of a couple of weeks ago. This is a nice 75-year-old patient who had reconstruction after breast cancer, and she had what was noted to be a ruptured implant on an MRI. And the question for the patient was, what should I do? What are my choices? What are my alternatives? And she's 75. She walks with an altered gait. She needs the support. She has an MRI-proven rupture of the right breast implant. And so what she did was she sought reconsultation with her own surgeon, who had certainly very well placed those implants. And this group, believe it or not, is the top 3 groups in the United States when it comes to breast reconstruction. And so she certainly sought them out, having had an MRI that showed what is a ruptured right breast implant. Now, what is interesting here is I happened to inquire and look at the different choices that the patient was told, and I'm going to read exactly what were the options. Quote, number 1, do nothing. Leave the implants alone. We did discuss that the capsular contracture will likely progress, and she could end up with constant pain from the capsular contracture. Believe it or not, this is a patient who has a ruptured implant. No one should live with a ruptured implant. So this is a wrong answer, and as wrong can get. No one should have to live with a ruptured implant. It is not normal, not healthy, especially when she has a capsular contracture where she has a hard calcified capsule on the chest that is causing her harm and pain. So that is not even an option if you were to consider this patient if she were to come to me. The second option that she was given, quote, remove the silicone implants. We discussed that we could remove the implant bilaterally, but she would lose volume and would be more ptotic. Now, this is also a wrong answer in my textbook, in my discussion with this patient, because if you remove this ruptured implant and the capsular tissue and that hard capsule that is around the implant, she will only be left with what is a flat chest aesthetic closure. And this is a very reasonable and healthy choice. This is what was discouraged for the patient. And unfortunately, this is absolutely the right answer. And this was basically not what was recommended per the discussion, because the patient said that this is the third choice is what she was told. Number 3, exchange of bilateral breast implants. We discussed that this would take me approximately 3 to 4 hours to do. We could tailor her skin and exchange them for something smaller or the same size depending on her desires. She also asked if she could just exchange the right implant and capsule. I did agree to this, but I did discuss that since they are almost 20 years old, it might be best to exchange them both if we are going to proceed. So the question is, why would you want to, in a 75-year-old, replace them, and now 10 years later, she's going to have to live with possibly another capsular contracture, another rupture, other problems, and you do not want, when you're to be 85, to have to go through more surgery or other surgeries. And again, the bottom line here is, if a patient goes to a plastic surgeon seeking answers, you will see you have to be very careful with what type of answers are given, even though they are the top 3 plastic surgeons in the country. The point being here, you have to do your homework. And this is what I find in the world that we live in today. Many patients are now advocating for themselves. They are doing the research themselves. They're overriding their local primary care doctor. They're overriding their local plastic surgeon. They're taking the initiative in their own hand and making this decision to explant completely, definitively, sincerely, such that when they look back at it, you will see the patients are only happy that it was done in the manner as described, where they know what they're signing up for, and they certainly want explantation. One big important point to note here is, if you ask all my patients who have explanted, they almost always say two things. Number one, they wish they had never gotten implants. And number two, they wished they had removed them sooner. And this goes to showing you that implants are not safe devices, and there is more and more of a notable presence on social media and the magazines, journals that are now what is highlighting the obvious. The local news channels are now bringing forth the patient's concerns and the harm that they went through when they had implants. And breast implant illness awareness is being made more and more, not only by the patients, but by the many other news agencies as well, because the obvious is becoming very apparent. The other thing I want to mention here is a lot of celebrities over the past several years have come forth, including the famous race car driver Danica Patrick, and amongst the many others, who have highlighted how they were hurt by the implants and what relief they sought when they had their implants removed. Now, one thing I want to also bring forth to someone's attention is, how do you know you're going to find the right surgeon? How do you know you have confidence in your surgeon? And so there are many factors that one can look at and say with absolute certainty and definitive confidence that your surgeon is the right surgeon. The first and foremost thing is your surgeon should be actively and openly accepting the fact that breast implant illness indeed does exist. I find, by looking at and talking to a lot of patients who come to me from all over, that many surgeons who are doing the surgery don't even openly declare that breast implant illness is a real entity. And this is a shame, because breast implant illness, as we saw earlier in the black box warning, it is a true entity. It is certainly being recognized. Remember, the breast implants have been banned before, and it certainly does exist. So why would someone go to a surgeon who does not even want to accept the fact that this illness exists? If they're not going to even want to accept the fact, how are they going to even do the surgery? Now, the second thing here is your surgeon should only be explanting, which means your surgeon cannot be putting in implants. If your surgeon is putting in implants, then they're trying to capitalize on this situation where they want to explant as well, which is wrong. Why do harm? Remember, the oath we took is do no harm. And why do a surgery where the patients ultimately only complain of the hurt and harm? They're not lifetime devices. So it is important for you to choose a surgeon who's only explanting. And you certainly have to be very careful. Even within that group that you're seeking out, you must confirm that there is not another partner who's augmenting. Because what is interesting is a year ago or so, a group sought me out and they wanted to buy my practice. And they thought that I was not doing a efficient job marketing myself. And they said, well, first thing we're going to do is we're going to hire another plastic surgeon who's going to augment so we can capitalize on those many other patients who you're missing out on. And we will have you just explant so that we can market you better. And I thought that was, very unprofessional and evil, that they would basically want to capitalize. And they said, well, just offering a service. Remember, this whole surgery is all about integrity, professionalism, respect, and the only and one interest should and must be the care and complete devotion to the patient. And the interest should not be to make more money at the expense of the patient. And so going back to, you should look at the group as a whole and make sure there is no other surgeon within that group who's augmenting, and this other surgeon is being made to be sold as only the explant surgeon because he's now more marketable. So you want to be very careful with that. The entire group, the surgeon should only be explanting, because anything that they say or do will be not having any weight or value to it. if I start augmenting tomorrow, all what I have said goes down the drain. And this is the whole essence of the integrity and professionalism, do no harm. Now, remember, if I were to augment or anyone were to augment, it takes almost 45 minutes to an hour. Explantation, when done properly, such as in my hands, it takes almost 4 hours, plus minus, sometimes 5 hours, sometimes 6.5 hours, depending on the size of the implant, if it's ruptured or not, if there was a residual capsule from the first set or not. And so if someone is only explanting and the whole group is only explanting, then you know with definitive certainty that the surgeon is going to do the right surgery, that he or she is going to be genuine about it, and that he or she is sincere about it. And this is where you will see, what are the 5 or 6 criteria that one needs to consider when they're looking for a surgeon. Number one, they should only be explanting. And so that is, again, validation for the fact that in the same time period, they could have done 3 augmentations, but they're choosing only to explant. So that is the first and foremost. And absolutely no giving into the fact that, well, he does both and, he seems sincere. No, your surgeon should only be explanting. Number 2, your surgeon should be taking high-definition pictures and videos of the chest wall showing complete removal of the entire implant capsule and all of that inflamed tissue. Because if you ask me, this is the one and only and ultimate proof that your surgeon is doing the right surgery. Because what could be a bigger proof than the chest wall itself being shown that there is no capsular tissue remaining behind, and that all of that capsule indeed was very much removed, and that you have now what is raw muscle. That means the fascia of the pectoralis minor, fascia of the serratus anterior, the fascia of the intercostal muscle was removed along with the periosteum and the perichondrium, because this is the ultimate proof, and from one patient to the next. The third thing is the surgeon should have a very good internet/social media presence on YouTube, Facebook, such that he or she is actively talking about it and his or her patients are validating the fact that the entire capsule was removed, because that's a check and balance on that surgeon. And so that is very important for the patients to kind of document their journey with that surgeon, and to it clearly demonstrates that the surgeon is doing the surgeries in the manner that he or she is. Number 4, that the implants are returned to the patient. I have talked to a lot of patients where the implants were ruptured on the way out, and the surgeon said that they did an en bloc, and that is virtually impossible. So returning the implants to the patient is one other indicator that kind of validates the fact that the surgeon is doing the right job. The length of the incision should be approximately the diameter of the implant. The point being, if someone has a 600 cc implant, so you can imagine the 9 centimeter incision is certainly going to be a very appropriate incision in order to remove this implant completely, definitively, sincerely. If you see a patient who has had a 3 centimeter incision and a 600 cc implant was removed, there is no way that this is even humanly achievable. And you know automatically that there was a compromise in the en bloc or 100% total capsulectomy, because the surgeon has to be able to see the dissection area. Now, number 5, the capsule must be sent to pathology, not only for oncologic reasons to rule out the BIALCL, the rule out breast cancer, rule out the squamous cell cancer, but also serves as proof that the entire capsule was removed. So again, if someone had a 600 cc implant and the amount of capsule that was removed was 3 or 4 centimeters, you know clearly, without a doubt, that the capsule was not removed in its entirety, and that automatically basically puts into question if the whole capsule was removed or not. And clearly that is classic firm evidence that the capsule was cauterized or left behind. And so the capsule must be sent to pathology, not only to rule out the BIALCL, but also to document clearly that the entirety of the capsule was indeed removed. When the pathologist sees the capsule, they always get a ruler and measure the dimensions of the capsule. So if they measure 3 or 4 centimeters and this was a 600 cc implant, clearly the capsule was not removed in its entirety. So the next thing is the length of the incision we talked about, and the length of the surgery in itself. So on average, I take 4 hours plus minus to remove like a 325 cc very average implant from start to finish. And this is the type of surgery that must be done in that period of time, given the nature where all of that capsular tissue is removed. I just finished my 5 cases in California this past weekend, and one of the anesthesiologists that I worked with, who is a almost 35-year-old veteran, he goes around for many different plastic surgery centers, and he was telling me he has worked with a lot of other surgeons who explant heavily in California. And when he saw my technique, he said, well, your technique is so different compared to the other surgeons he has worked with, all of those other surgeons, where he said that those surgeons would be doing 4 of these cases in a day, or they would be doing each surgery in an hour and a half or 2. Automatically, this is a big red flag if your surgeon is doing a surgery start to finish in an hour and a half or 2 hours, because you cannot humanly achieve this task of removing the whole capsule below the muscle directly on top of the rib in an hour and a half. Again, in my experienced hands, having done thousands of these, it takes almost 4 hours. And this is why taking the time to dissect is key. And remember, it is all about all these 6 things. Number 1, the surgeon is only explanting. Number 2, there is a social media validation, verification that he truly is a firm believer in breast implant analysis, discussions like these that I'm doing right now. Number 3, that there is basically reviews, validation on social media by the many other patients that this surgery is done in the manner that the surgeon describes. There's high definition pictures and videos of the surgery that were done of the chest wall, showing complete removal of the capsule, because this is the ultimate and only proof that the surgery was done. So extremely important, point number 3. Number 4, the length of the incision is approximately the diameter of the implant. The implants are returned to the patient because that is proof that they were not ruptured on the way out or damaged. Number 6, that the capsular tissue was sent to pathology, because that in itself is documentation. Whatever was removed, you can go to the pathologist's office the next day and say, I want to see my capsule because I want to see the quality of the explant. And number 7, you want to make sure that the length of the surgery in itself is approximately 4 hours plus minus. So that all of a sudden kind of gives you the very good confidence that the surgery is done right. There are many patients that I have talked to over the years, their surgeon never even documented in the operative note that the whole total capsulectomy and block was done. There are patients that I have talked to that stated that their surgeon did not even take pictures and videos of the chest wall or cutting open of the implant capsule on the table, and they said it was a HIPAA violation. Remember, it's not a HIPAA violation if you yourself, the patient, is getting the pictures, videos of the chest wall showing complete removal of the capsule. If you get your gallbladder out, who cares? But when it comes to explantation, every surgeon has their own take, their own formula, their own process, their own on-the-job training. Remember, this is a surgery where if you go to the 100 different plastic surgery fellowship programs, no one is taught this on a regular daily basis on how to do a proper explant with a total capsulectomy or an end block. This is literally the surgeons realizing it, on-the-job training, or the patients are asking for this, so I'm going to go ahead and see if I can deliver it to them. There is no true textbook that even talks about it. So this is, again, extremely important for you as a patient, as a consumer, because remember, what is the worst-case scenario in all of this? The worst-case scenario is you have faith in a surgeon because he sounds good. He's got a nice office in the middle of, God knows, Beverly Hills with a nice marble building, and he's got a good, very nice internet presence, nice website, but now he's not able to reproduce these 7 things, 8 things. All of a sudden, you have big red flags about how the surgery was done and why it was not done in the manner as described. And remember, your surgeon should be very open, very proactive, and very transparent into showing you exactly what the surgery was, how it was done, and in the manner it was done. And the operative record in itself should dictate clearly how the surgery was done, what was accomplished, and what was left behind. So very important for the patients to do their homework. The other thing that I've heard over the years, that the surgeon did not return the implants because they were damaged or ruptured saline implants on the way out. The surgeon kind of poked a hole, pulled the ruptured saline implant out from a small incision under local. So this is a big no-no. I have heard that the surgeons are not even documenting that a total capsulectomy was done. They mentioned capsulectomy was done. It may be 10% capsulectomy, 50%. So the surgeon has to document in their operative note. Now, the other thing here is that the surgeon should clearly be showing and giving the patient all the right pictures, operative neck records, whatnot else. Again, the complete transparency so the patient has the peace of mind. Again, going back to what is the worst case scenario, this patient has chosen a surgeon, she gets their explant, and unfortunately the capsules are left behind. The surgeon thought he could remove him out of good faith, and the next thing you know, there are residual capsules, and the patients had their capsules cauterized. Now remember, it is one thing that the capsule is cauterized and left behind. Is not the same thing as physically removing the capsule. And this is what I alluded to earlier. Whenever I remove the implant and capsule, I essentially remove the fascia of the pectoralis minor, fascia of the pectoralis major inferiorly, the fascia of the serratus anterior, fascia of the intercostal muscle, and I also remove what is the periosteum and periochondrium, and that essentially ensures from me that the entire implant capsule indeed was removed in the manner described without touching the breast tissue. Now, another question that I get asked a lot, what is the con procedure? How is it that I'm doing it? And this is very important for the patients to realize, how the surgeon does it. And so in my practice, this is the con procedure. And number one, I don't use drains. The last time I used drains was well over 6 years ago because the drains are not truly required. As you will see, the thousands of patients that I have taken care of, even the international meeting that I presented at, I said that if the surgery is done right, the drains are not required. The blood loss is less than 5 cc's, and well over 99.7% of the cases, all of the capsular tissue is removed. None of the silicone spills into the chest. All the badness is removed in the end block fashion or 100% total capsulectomy. So now the need for the drain is not there. If a surgeon leaves the capsule behind or lets the silicone spill into the chest in case this is a ruptured silicone implant, or the surgeon is rushing through the surgery and making a lot of irregular cuts and is not very meticulous in the dissection, now the drain becomes mandatory. And you will see, unfortunately, you see a lot of surgeons using drains for 2 weeks, 3 weeks, and they're collecting a lot of fluid because the surgery was done inaccurately, incompletely, and there was a lot of badness left behind, and now the drains are required. So the other thing to point out here is, if you look at my thousands of patients, how many of them go online and document that the surgeon was great or the experience was great, but they needed drains later on when they headed back to like Texas or New York? None of them do because the drains are not required. Now remember, the drains themselves are a problem in itself, meaning if the bulb syringe opens and now that fluid inside the drain can backtrack, or the tube in itself can dislodge in and out of the chest, that in itself can be problematic. And sometimes the drains themselves can cause irritation and induce fluid formation. So the drains are bad in every regard. Now, I have used drains plenty of times in my tummy tucks or a neck dissection that I did for a cancer patient. Drains are a very important point of what is plastic surgery, but in explant surgery, drains are not required, to the point where I say to you, if your surgeon is using drains, extremely high chances your surgeon is not doing the right surgery. So very, very important point. So going back to the con procedure, drains are not required. Number two, no lift. You will see a lot of patients go to doctors who always do a lift, who always place drains, and they're always doing this S lift, J lift, or a full lollipop anchor lift. I will tell you, in my practice, well over 80% of the patients do not need that unnecessary lift. I do what is a pseudo lift, And this is where I find most of the patients, 80% or more, are very happy and content. Yesterday, I saw a 79-year-old patient. She had a ruptured implant that I removed on the right, and between the excess skin that I removed and the way I contoured her with the tissue rearrangement, she truly was not a candidate for a lift because she already got her lift in the way I reconstructed her. So there are a lot of factors that come into play that dictate if a patient needs a lift or not. So a patient that I took care of had 900 cc implants, and the largest one that I've done is 1200 cc implants. Those patients clearly need a lift because their skin is so much stretched out. But the many patients in their 550 cc implant, someone 37, and done relatively well with the pseudo lift, even these patients do not need what is a true formal lift. In my experience, I find there are several factors that come and help in the process of a patient not needing a unnecessary lift. Remember, I love to operate. I would love to do a lift on everyone. Remember, a lift is not required because the patients do very well without the need for that full mastopexy, lollipop, anchor, or S-lift or J-lift. Now, in my way, the way I do it, the con procedure, I removed the excess skin at the bottom where the implant was working as a tissue expander, a horizontal incision only that hides right in the crease. That in itself pulls that excess skin out so that when I do end up suturing with 4 layers of all absorbable suture, you will see that lifts the breast tissue up and also towards the midline. And now between, number one, the recoil of the skin and the breast tissue. The younger the patient is, the more the recoil of the skin and the breast tissue. Number two, between the gravitational pull of the implant down and pulling the breast tissue with the implant gone, the breast tissue in itself is going to recoil. Number three, between the muscle mass that the patient is going to add to their chest by gently working out, when I tell them the 5, 10, 15%, that is going to add some volume. Number four, when the inflammation subsides, you will see the skin's going to recoil even more and better. So that in itself helps when the inflammation subsides, that the breast tissue is going to recoil even more. So number five, you're going to notice that the patients sometimes have a chest wall contour deformity as a result of the implant sitting on the chest. And so with the implant gone, the ribs are going to kind of expand out because that's how normally the ribs are. They expand upward and outward. So now the indentation, that concavity, is going to be automatically fixed because the bone is going to remodel, and you're going to see that they're going to stretch out, i.e. the ribs are going to fan out, and that in itself will add an aesthetic contour to the chest and the breast area. And you will see that between the skin in itself recoils almost 30 to 40%, especially on a young patient. Most of the patients do not need what is that unnecessary lift, especially with the pseudo lift. The way I moved the breast tissue inward and upward, and I put 4 layers of sutures, 80% of the patients do not need that unnecessary lift. A lot is also dependent on how good your initial surgeon was. Now, if a patient has had 700 cc implant and is 70-year-old, you clearly will note that this patient absolutely needs a lift because of the lack of elasticity of the skin plus the large size of the implant. So again, going back to the point, no unnecessary surgery, no unnecessary cutting around the nipple areola up and down, and avoiding potential nipple necrosis, skin necrosis. A lot of patients who have had these type of lifts, when you talk to them afterwards, let's say 100 patients who have had these cuts around the nipple areola up and down, if you ask them, depending on their surgeon technique, among others, a small subset have had nipple necrosis, skin necrosis, or wound dehiscence where the wound separates, because remember, this is inflamed angry tissue. If you talk to 100 of these patients, some of them will report maybe 1, 2, 3, 5, 7% that they have nipple sensation loss, pins and needle sensation. A good number of them, when they pass their hand around their nipple, chest, breast area, they're going to notice that they have these irregularities because this is where the cuts were made, and now you have fat necrosis, you have scar tissue, maybe you may have irregular contour because this is how the skin healed, and now you're going to be questioning yourself, is this a normal self-monthly breast exam to screen for breast cancer? Do I need to get a biopsy because an abnormal finding was noted on the mammogram? Is it scar tissue? Is it suture granuloma? And now the patient's very anxious. Remember, in the United States, 1 out of 8 or 9 women will get breast cancer, and you do not want to complicate the screening for breast cancer. So no unnecessary cutting up and down around. And for the same reason, fat grafting is a big no-no to the breast tissue, and we'll talk about that shortly. So going back to the con procedure in detail, you have no need for drains, no need for the unnecessary lift. We talked about the capsules. The capsules are always sent to pathology. Rule out that rare BIAL, CL, CD30 analysis, rule out lymphoma, rule out malignancy, rule out anything abnormal, rule out silica, giant cell reaction. If there's any silica that's present. Number 4, microbiology cultures are done for aerobic, anaerobic, and fungal so that we know what it is and what it is not. The microbiology lab takes the swabs that I take in between the implant and the capsule and send them off to the microbiology lab so we will know what is going to grow on the petri dish. Number 5, the implants are always returned to the patient so the patients know what was in them. Unfortunately, 10-15% of the times I find there is a discrepancy. The patient says, well, I never signed up for saline implants, and the patient's got saline implants removed. Or one was saline, believe it or not, the other one was silicone. One was Mentor, the other one was Allergan. One was above the muscle, the other one is below. One patient even had a card that said this is not the same implant because it did not match the serial number of the implant and the card that the patient had gotten from her surgeon. Again, this is very important to basically return the implants to the patient. And plus, there is a psychological closure that these implants were removed in the manner and they were not hurt or disturbed or basically ruptured on their way out. Another big aspect of the anesthesia is basically the